With a prevalence of up to 10%, polycystic ovarian syndrome PCOS is a prevalent and confusing endocrine condition affecting women in their reproductive years. Menstrual cycle irregularity, hyperandrogenism, insulin resistance, and obesity are among the clinical manifestations of the syndrome. However, they are not always present. PCOS is a metabolic condition that affects a number of hormones including insulin, which is called hyperinsulinemia, androgen hormones, which affect testosterone, luteinizing hormone, and follicle-stimulating hormone, but its specific causes are unknown. Although patients do feel more social aspects including increased sensitivity to others, melancholy, and sexual dysfunction, there are no particular pain sensations that they specifically experience. The early pubertal years are when PCOS develops.
The ovarian cycle and the processes of folliculogenesis are disturbed in polycystic ovary syndrome. The development and maturation of follicles to release egg cells are impeded by abnormal hormone levels. These immature follicles gather in the ovaries instead. The follicles can therefore be present in 12 or more afflicted women. High levels of androgens, also known as hyperandrogenism, are a significant characteristic of PCOS. Androgens are regarded as masculine hormones that are produced by the adrenal cortex and the ovaries in females.
Androgens are further degraded in women to produce a big amount of estrogen and a smaller amount of testosterone. Although in a modest concentration, testosterone is present in all women. The hormone testosterone has benefits for reproduction, bone health, and libido. Excess testosterone triggers early luteinization and prevents the selection of dominant follicles, which prevent ovulations. In some PCOS situations, high amount of androgen might also account for excessive hair growth and ongoing acne, and also known as acne vulgaris. That excessive androgens can inhibit the synthesis of estradiol, which is a growth hormone essential for the proper development of antral follicles in reproductive organ tissues. Antral follicles that have grown early are caused to cysts on the ovaries. Theca cell hypoplasia, a rise in antral follicles, and an increase in ovarian stoma are characteristic of polycystic ovaries. These theca cells will develop into follicles as they grow. Once a tiny cyst has formed, the follicles will start secreting androgen hormones on their own. Up to 33% of PCOS cases have polycystic ovaries.
LH and FSH are produced and released by the pituitary gland, a structure located in the brain. These hormones are necessary for reproduction because LH stimulates and produces androgen, and FSH is in charge of stimulating and maturating an egg before it is released during ovulation. These hormones are out of balance in PCOS. A decrease in FSH limits the stimulations, maturation, and release of an egg during ovulation, while an increase in LH causes an excess of androgen that can be converted to testosterone. Furthermore, insulin resistance is a common symptom of the condition. Based on research, insulin resistance occurs in 60% to 80% of PCOS cases. The body cells are unable to use the hormone insulin to digest glucose for energy in cases of insulin resistance. Glucose will be stored as a fat in the body when there is an excess of it. Some people with PCOS experience weight gain for this reason. Additionally, insulin has a significant role in the release of androgen hormone. When the body has more insulin than is needed, it will stimulate the body to produce more estrogen. Another causes that can link with PCOS is stress management and wrong dietary.
Next one is clinical signs. The first one is hirsutism. Hirsutism in women is the growth of terminal hair in adult male distribution. For example, excess facial hair, hair on the chest between the breasts, and hair on the lower abdomen. Hirsutism in PCOS reflect androgen excess. The most dominant is dihydrotestosterone that directly influences the size of the hair follicle produced. The next one is obesity. Obesity contributes to insulin resistance, which lead to hyperinsulinemia. Hyperinsulinemia will interact synergistically with luteinizing hormone LH as a co-gonadotropin within the ovarian Thika cell, making the androstenedione and testosterone level become high, lead to insane ovarian androgen production.
Next is irregular menstrual cycle. This happens when an imbalance hormone between luteinizing hormone LH and follicle-stimulating hormone FSH stimulate testosterone production in inappropriate amounts. This can increase testosterone levels, which can interfere with the menstrual cycles and prevent ovulation. Without ovulation, a regular period cannot happen. The last clinical sign is androgenic alopecia. This is a condition in which hair on the scalp gradually decreases in thickness. The thinning usually starts near the hairline and spread backwards along the center of the head in a triangular pattern. This pattern referred as a Christmas tree pattern, where the hair loss is wider at the front and narrower at the back.
Traditional diet preferred are to drink enough water because inadequate water consumption might lead to hormone imbalance. Next, they are advised to consume low-fat foods. Obesity and insulin resistance are caused by consuming foods with a high fat content. Unhealthy food should be taken fewer since it has chemical compounds, sugar, and calories content that contributes to weight gain. Then, consume lots of vegetables and fruits. 2 portions of fruits and 5 servings of vegetables are recommended for adults. Next, high-protein foods should be consumed since they can help to regulate blood sugar level. Carbohydrates were also advised to be consumed in moderation to regulate the amount of sugar in the blood.